the opportunity to talk to your group. What I hope to achieve in the next 30 or 45 minutes, we have a Ross scheduled this morning, so my fellow will get started. But basically, I want to just kind of take you through my approach to treating aortic valve disease with a specific focus on valve repair and then options for non-elderly patients when the valve is not repairable, and just talk a little bit about the implications of the choices we make in the office and the operations we do with regards to kind of long-term outcome, quality of life, etc. Now, for some reason, there we go. Okay. So I'll start with a case. This is a 48-year-old lawyer who had a 6-month history of shortness of breath, NYHA class 2, otherwise fit, runner. And you can see here from the, so past medical history is relatively unremarkable with the exception of an SVT. And during the workup, we obviously start with an echocardiogram. I always do an echocardiogram at St. Michael's Hospital. I trust the echoes here. They're done really quite well. And so that's really the reference testing. And then often the young patients have associated aortopathy. And as you all know, echo is excellent for measuring aortic root dimensions, not so good at measuring distal aortic, ascending aorta arch, and actually not great at measuring the LVOT or the aortic annulus. So CT, I've used CT initially for evaluating patients with aneurysmal disease, but even young patients who were considering for Ross or other complex root procedures, I often do a CT, even if the aortic dimensions are not enlarged, to help really with some fine tuning of parameters like the LVOT. And now we're measuring the pulmonary artery in order to help size the pulmonary homograft if someone's being considered for a Ross. So this patient had on echo an EF of between 43 and 49%. Simpson's biplane in the evaluation of aortic valve disease for accurate LV assessment is important to me, as is LV dimensions, not just the two-dimensional parameters like end diastolic and end systolic dimension, but the left ventricular end diastolic volume index, very important. So, and then the quantitative and semi-quantitative parameters of AI are also important. So you can see this patient on echo had severe AI. I'll hopefully have some images. Large LVOT, which is not unusual in young patients with bicuspid valve disease, and a very enlarged left ventricle with a left ventricular end diastolic volume index of 171. So here's the echo, and you can see that the LV is abnormally large. It's important to look also at the two-dimensional pictures as far as how the valve coaps in parasagittal long axis view as well as short axis to get an idea of the valve morphology. And then, of course, pictures with color, which is we evaluate from all various views, as you all know. So how do I approach somebody with aortic valve disease? So the first question I always ask is the valve repairable? Now, this often and usually refers to patients with aortic insufficiency. And so if the valve is leaking, but morphologically relatively normal, then most likely the valve is repairable. Now, just to give you a baseline reference of kind of what is done across the STS database, 13% of patients that have been coded as having aortic insufficiency in the STS database end up getting some form of valve repair. And we had a meeting at the AATS among experts in aortic valve disease and valve repair, where we sort of talked about what the right number should be. And I think most people think that, at least people who do valve repair, valve sparing operations, that number should be probably closer to 60%. So there's a lot of valves that are not being repaired, and instead people are getting mechanical Bentals or tissue valves. If the valve looks like the one on the bottom, obviously there's not going to be a repair strategy. And in that case, we're going to be proceeding to some form of replacement strategy. The timing of surgery is important. This is usually relatively straightforward in patients who have aortic stenosis, less so when patients have aortic insufficiency. As you all know, many patients enter this latent phase of the disease process, whereby they have severe aortic insufficiency, and if they don't have symptoms, deciding on the timing of surgery is not black and white, and often depends on serial longitudinal assessment of LV function and LV size to help guide when to pull the trigger for surgery. And getting it exactly right can be tricky. Obviously, we don't want to be operating on people with relatively normal sized ventricles and clearly hyperdynamic ventricles. But at the same time, I also see a lot of patients who come for surgery quite late, where they've been in that kind of compensated phase and then for whatever reason fall off the cliff and their EFs are 20 or 30%, and clearly we've waited too long. When we're considering, what kind of operation to offer the patient, we obviously have to factor in other things that influence the risk of surgery, such as patient age, their level of physical activity, occupation, young females who still have not had children or a desire to have children. We have to consider the surgical option and the type of operation, and then other things that affect risk level. So repair is usually in the form of some form of valve sparing root replacement. This can, and we'll go into the options in a minute, or isolated valve repair if there's no aortopathy. And if we're talking about replacement, particularly in patients that are non-elderly, and I define that as sort of less than 60, although one could argue that patients in their early 60s who have at least 15 or 20 years of life expectancy, depending on their level of physical activity, one could consider them for a ROS. But as the patient population is older and higher risk, then we start thinking about more standard conventional options like tissue or mechanical Bentall, or straightforward tissue or mechanical valve replacement.
The guy is 48.
So this is
severe eye, and the aortic valve is right cusp is through.
So this is a patient. This is the patient that I showed in the first slide. So what we do when we get to the operating room is we do. I always tell patients, based on the preoperative echo, if they have no calcium on the valve, if there's no stenosis, if there's no calcium on CT, then we always look for a repair option. I don't typically order preoperative TEEs because I don't find that it doesn't help the decision making. The decision to operate is not based on the TE, it's based on the other factors that we've just talked about. And ultimately, the decision to fix the valve will be made. So once the patient has an indication for surgery, then we're prepared to either repair the valve, do a ROS, or do a valve replacement. And so the final arbiter of whether the valve is repairable is intraoperative inspection. So once we've arrested the heart, transected the aorta, you can see this patient has a tricuspid valve. We assess the valve, and valve assessment includes looking at the cusp, whether or not there's calcium, degenerative disease. We look for fenestrations. Many valves that have been subject to aortic insufficiency and some degree of aortopathy do often develop fenestrations. The fenestrations usually occur at the insertion at the commissure. However, and usually we largely ignore those. If they have large commissural fenestrations, that may be an indication to not spare the valve, but that's relatively uncommon. We measure the geometric height. So you saw me using the ruler, and we measure from the base of the cusp to the free margin. And in a patient with a tricuspid valve, we need at least 17 millimeters of geometric height. And in a bicuspid valve, we need 18 to 19 millimeters to be able to make that valve competent. So if the valve is restricted and only 15 millimeters, we probably would move to a replacement option. And so that's generally what we also measure the LVOT with various sizers to get a sort of global sense of LVOT, cusp morphology, geometry, and health. And then once we think that the valve is sparable, we proceed to this step, which is here I'm just measuring the LVOT. You can see it's quite dilated. That's a large valve sizer. And so if we're going to repair this valve, we're going to have to attend to several issues. Annular dimension. We're going to have to potentially repair the cusps, and then obviously recreate the sinus of Valsalva. And you can see the coronary arteries have been mobilized. Here we're just measuring with a Hagar dilator. And so finally, we try to get a sense of how we can make this valve competent. And if we think that we can make this valve work, we're going to proceed to a valve repair option. Any questions so far? So by plicating the margin of the right coronary cusp, which I'm sort of doing here with the forceps, we can see that this valve will become competent. You can actually see that the right cusp is prolapsing. So what we've decided to do is a valve sparing root replacement. So we've already used a graft. Here I did a Yakub and an external annuloplasty. This is just a saline test. We turn the LV vent on at 400, so we're sucking in the LVOT. This is a kind of a poor man's test or poor person's test, and you can see that the saline doesn't drip through. So it's our first indication that the valve may be competent. And then I use something called the Schaefer caliper, which you see here, and I set the height of this at 9 or 10 millimeters, and that's going to give us an idea of what the effective height of the valve is. Let's go to the next slide. I'll just skip this. So, you know, one of the things that people debate about is how much aortic insufficiency is too much to warrant moving to a valve replacement option versus a valve repair option. And I would say that it's not the amount of AI that is important. It's the health of the cusps, the geometry of the cusp. If you have severe aortic insufficiency and normal looking cusps with a good geometric height, then those valves should all be repairable. If you have severe aortic insufficiency and a very short retracted cusp or calcium on the cusp, then that valve may not be repairable. So although the degree of AI preoperatively correlates with the probability of repair, it's not the amount of AI itself that determines the repairability, it's the cusp geometry and cusp health. These are the various mechanisms that cause AI. So you can have a relatively normal valve and normal root, but if you have a large ascending aneurysm that causes dilatation of the sinotubular junction, that can result in varying degrees of AI, and the operation to fix that would simply be replacing the ascending aorta, hemiarch, and remodeling the sinotubular junction. Patients with aortic root aneurysms. Now, one thing I often see is people, cardiologists, surgeons will say, well, patient has an aortic root aneurysm and therefore they have AI. It's not the dilatation of the sinuses of Valsalva that causes AI. It's the associated pathology that leads to AI. So patients with aortic root aneurysms often have what's called annulo-aortic ectasia. And so if you have a dilated annulus, that can pull the aortic valve down and result in AI. Similarly, if the root aneurysm extends into the ascending aorta and there's dilatation of the sinotubular junction, which is the anatomical point where the ascending aorta meets the top of the commissures, if the sinotubular junction is dilated, that'll also cause AI. But if you have a patient with a normal sinotubular junction and normal annulus, you can have infinitely dilated sinuses of Valsalva, provided you have normal cusps, you will not have aortic insufficiency. And we see that in patients with congenital sinus of Valsalva aneurysms. And then finally, patients with normal aortic dimensions, if they have inherent pathology of the cusps themselves, whether it's perforation from endocarditis, prolapse from degenerative disease, or restriction of the cusp, they can also have varying degrees of AI, and those patients are less likely to end up with a valve repair option. I'm going the wrong way, sorry. So here's another case. Here's a patient with an aortic root aneurysm. The patient had angina as well as class 3 NYHA dyspnea, ex-smoker, good LV function, 4+ AI, ventricle kind of borderline dilated. And you can see on CT, the annulus measures 26, so upper limit of normal, 60 millimeter root. But importantly, the sinotubular junction is dilated. And if you look at the short axis view of the CT on the right bottom panel, you can see that there's actually a coaptation gap, and that's what's causing the aortic insufficiency. So here we're looking at the preoperative echo, both with and without color, and you can see a large jet. Often, failure of coaptation of the valve causes a central jet, but more often than not, there's some directionality to the jet, and that does not necessarily mean that the valve is not repairable. And again, looking at it in short axis, you can see that there's somewhat of a gap in the center. So well, I've kind of gone over this, some of the things that we do to assess both the repairability of the valve as well as the post-repair result. This is important for me as a surgeon, but it should also be important as an echocardiographer, because these measurements, which we actually obtain directly in the operating room, can be measured on echo, and there is good data to correlate these measurements with long-term freedom from reoperation for aortic insufficiency. So there's two parameters that are important. One is called the effective height, and so if you're measuring in a long axis view, you can actually on echo you can draw a line from the basal annular ring or the line where you would normally measure the LVOT up to the top of the valve, and that we call the effective height. Anything over 9 to 10 millimeters generally predicts a fairly, provided you have little to no AI at the end of the repair, predicts a very good long-term result with a high degree of freedom from reoperation. The second measurement that we look at, which is maybe easier to obtain on an intraoperative TEE, is what's called, it's this measurement ZK, or otherwise known as the coaptation height. That's the measurement for which the leaflets are actually touching or coapting. And if that measurement's greater than 4 millimeters, that also predicts a good long-term result. So imagine if you have a valve that's coapting and it's competent, but there's only 1 millimeter of coaptation height. In other words, the leaflets are only touching over 1 millimeter of length. Any small changes in geometry of the root or the valve coaptation surface may result in recurrent AI. Whereas if you have a centimeter of leaflets touching one another, then you can have changes in geometry without recurrent AI, and that's why it's predictive of good long-term results. Here are the various type of operations we do when we're considering valve repair. There's in the cardiac surgery literature and at meetings, people seem to be divided very emotionally into two groups. One is the Yakub camp, the other is the David camp. And so the Yakub's known as the remodeling procedure, whereas the David is known as the reimplantation procedure. Both are aortic root replacement operations. Both require mobilization of the coronaries. The difference is in the Yakub, we scallop the graft and sew it in as shown in the picture, whereas the David, the graft goes all the way down and is it goes around the basal annular ring externally, and then you reimplant the valve completely within the Valsalva graft. So why do people choose the various options? Well, there's some indication in the literature that if you have a dilated annulus and you get a remodeling procedure, because there's no stabilization of the basal annular ring or the kind of aortic annulus, although the aortic annulus is a crown-shaped structure and not a circular structure, but because there's no stabilization of that annular plane, there's a higher incidence of AI and a greater risk of reoperation, whereas the David stabilizes the annulus externally. People who do the Yakub say, well, you're not freezing the aortic valve within a non-compliant graft, and therefore it allows the aortic root to have that normal physiologic pulsatile expansion, and it's a more physiologic operation. While that may be true, I'm not sure it actually makes a difference, but the Yakub is a simpler and faster operation to do, whereas the David takes longer time. So a surgeon in France by the name of Emmanuel Lansec combined sort of the best of both worlds, and it's basically a Yakub with an external Dacron annuloplasty band, which provides annular stabilization, yet it allows for the physiological expansion of the root. So I actually do all three of these operations, and I think kind of using a tailored approach to your patient is always the best option. So on the case 2 that I showed, here's the preoperative echo. You can see there's severe AI, and here's the post-repair echo. There's trace aortic insufficiency, and we've measured. I think we're going to show that here. So here's the echo measurement of the effective height, it's 9 millimeters. And in fact, the valve is coapting along the whole effective height. So the coaptation height will be very similar, probably 8 to 9 millimeters as well. So here's the, how do patients do following valve sparing procedures? Well, of course, they are selected patients, but it's an operation that provides excellent 10, 15, and 20-year results. Survival at 10 years is almost 90%. And if you plot the age and sex adjusted population, it's really, that line parallels that. And you don't see kind of restoration of survival to normal with aortic valve replacement. And we'll look at that data in a minute. And then here's a comparison of reimplantation versus remodeling. And in this particular series, there was no difference in long-term survival. Freedom from reoperation, also at 10 years, excellent, 97% at 10 years, 94% at 20 years. So if you have a repairable valve, you really do have a good long-term outlook. And then there seems to be, over time, a little bit of a drop-off in terms of risk of reoperation between the Yakub in blue and the David in red. But again, now that we've added annular stabilization of the Yakub, these results over the long term may be more similar than this graph shows. Okay, so what happens when we don't have a repairable valve? So here's a case of a 52-year-old helicopter pilot from Newfoundland. Again, standard symptoms of severe aortic stenosis, shortness of breath, some presyncope, history of sleep apnea. Echo shows preserved LV function, bicuspid valve with a mean gradient of 57. LVOT was 2.1, no aortic insufficiency in a 93-kilo man with a BSA of 2.1. So again, we've measured the dimensions on CT. This is his valve and cross section. So how should we proceed? Well, the options are, standard prosthetic valve replacement, which is what he would get in most surgeons' hands in most centers, be a tissue versus a mechanical valve. There's been a huge move in North America to implant tissue valves versus mechanical valves. And so he'd likely get a tissue valve, though there are some people who would still implant a mechanical valve. Or should we be considering him for the Ross operation? So what's the data that drives the decision to do a Ross? You often hear a lot of surgeons say, I'm not a believer in the Ross. Well, I would say to those surgeons and to those non-believers that it's not, deciding to incorporate Ross procedures in your practice is not a matter of a religion. It's a matter of understanding the data, understanding the options. So here's a paper from the Montreal Heart Institute. They looked at 469 patients, young patients, less than 65, who underwent isolated aortic valve replacement with a mechanical valve, and they excluded anybody who was getting concomitant operations such as coronary bypass. They excluded reoperations, they excluded emergencies, they excluded endocarditis, and the average age was 53. So the point is that this is pure elective young patients without comorbidities having surgery to replace their aortic valve. Follow-up was 9 years, 95% complete. And so here's the survival free from reoperation. So at 10 years, 1 in 5 patients were either dead or reoperated on. So think of that another way. When I have a 50-year-old in my office who I'm offering a mechanical aortic valve to, they often ask me, they say, "Doctor, when I get my valve replaced, will I live a normal life?" And of course, the tendency is to want to reassure them and say, yes, you're going to live a normal life as if you didn't have aortic stenosis. But the data says otherwise. The sober reality is that young patients have an excess mortality after prosthetic valve replacement. And the reason for that is that the prosthetic valve supplants the disease of aortic stenosis for the disease of a prosthetic valve. So there's this signal, and there are many studies, I'll show you 1 or 2 more, has been recreated in other data sets. This was a large study done in California based on a California database of a large amount of patients looking at the performance of mechanical or biological valves for AVR or MVR. This was in almost 10,000 patients that had isolated AVR, again, young population, less than 65. So if you look at patients between the ages of 45 and 54 years of age, this is the probability of death over time after a bio-AVR or mechanical AVR. So again, at 15 years, straightforward biological or mechanical valve, the chance of being dead at 15 years was in the range of 26 to 30%. That's horrendous for young, otherwise healthy patients. In the age group of 55 to 64, same signal that at 15 years, the mortality was 32 to 36%. That is not the normal adjusted survival for a population of this age if you match it to the sex and age matched population. This is one more study I'll show you, again, out of Montreal, looking at isolated biological AVRs, again, excluding sick patients, urgent reoperations, again, mean age 51, and looking at 10 years, the survival after a biological valve in young patients, 79%. Again, one in 5 are dead at 10 years. So I'm just going to skip this. So when we're considering what to do in young patients who have non-repairable valves, we're looking at not only trying to preserve or restore long-term survival, which mechanical or biological valve replacements do not do, but the ideal substitute for valve replacement should mimic the function of the normal aortic valve, which is to provide a valve that has laminar flow, excellent hemodynamics, low gradients, low thrombogenicity and resistance to thrombosis without the need for Coumadin or anticoagulation, and should be resistant to infection. We also have to factor in young patients often have high levels of physical activity, quality of life. 40% of patients who receive mechanical aortic valves complain about the clicking noise. It's quite disturbing. We have to consider that these patients have a prolonged anticipated life expectancy that's at least 15 to 20 years, and that options including mechanical valves expose them to valve-related complications such as bleeding, thromboembolism, degeneration, and reoperation in the case of tissue valves. So I'm gonna just skip this. So what is the impetus to consider a more complicated operation such as the Ross operation in this population? Well, this was a landmark paper published in Lancet in 2010. It was a randomized trial. It randomized patients, not just elective patients, but all comers. So patients with endocarditis, reoperations, high-risk patients with aortic valve disease to receiving either the Ross operation or an aortic homograft. And so this is the follow-up out to 12 years. And at the AETS in LA last week, they presented actually the 30-year follow-up on this cohort, and that will be published soon. And the survival is outstanding. So here's in black is the survival of the general population. So again, age and sex adjusted matched population. And the Ross survival mimics that. In other words, the Ross restores survival back to what you'd expect for that age and that age matched population. Whereas aortic homografts had a markedly different survival after 13 years. So in this randomized trial, the Ross outperformed an aortic homograft in a significant manner and also mimics survival of the general population. This is just other data looking at Ross survival over time. So at 10 years, Ross survival was 98%, not 20%, not 80% or 70% as we saw in the other studies for prosthetic valve replacement, and matched the Ontario age and sex match population. This is another study looking at long-term outcomes of Ross versus mechanical valve, and you can see the Ross outperforms mechanical AVR. So what are the advantages of the Ross? Well, it's the only option for valve replacement that actually provides a living substrate in the aortic position. So we harvest the pulmonary autograft or the pulmonary valve and transplant it as a full root into the aortic position. This valve is living tissue, remains living. And if you do autopsy studies at Ross patients that have died for other reasons, this has been done at various time points, 5, 6, 10 years out from surgery. This valve becomes indistinguishable from a normal aortic valve. It still has normal characteristics of an aortic valve. It is living tissue with healthy collagen, smooth muscle, fibroblasts, etc. It has the Ross has excellent hemodynamics. I've never seen a Ross come out of the OR or have an echo at 4 days, 1 year, or any of the Rosses I've ever done that has a gradient over in double digits. The gradients are usually 2, 3, 4 millimeters mercury, and I think you've all seen this in the echo lab. Patients generally have an excellent quality of life. There's better freedom from valve-related complications, low risk of endocarditis on the pulmonary autograft or the neo-aortic valve. There is a risk of endocarditis with the pulmonary homograft, and as such, we do recommend lifelong prophylaxis with antibiotics for dental procedures. And there's restored long-term survival, as I've just shown you. What are the barriers? Well, it's obviously, instead of a 2-hour operation, it's a 4 to 5 operation. It's technically much more demanding with many more steps than a simple AVR. Centers that do this at low volume have a higher complication rate. And if that complication rate is high enough, then it actually negates the benefit of doing the Ross in the first place. Young patients equals higher stakes. So you've got a young 35-year-old, mother of one who wants to have children. The tolerance for errors and complications, stroke, death, etc., are close to zero. So what is the Ross? Well, the Ross is, essentially just a fancy aortic root operation. It's in a sense, it's like a Bentall where we, isolate the root and we reimplant the autograft, the pulmonary root as a full root. So we do an annular, there's annular sutures, we reimplant the coronaries and then reattach either a tube graft or the ascending aorta. Here are the various steps. So this is harvesting the pulmonary autograft. So once we've opened up the root and made the decision to do it, here we're dividing in the top left panel, we're dividing the pulmonary artery distally. We normally divide it just prior to the bifurcation of the RPA and the LPA. Now, once we've done that, we inspect the pulmonary valve. We want to make sure it's tricuspid. You can have a bicuspid pulmonary valve, and in that case, we might abort. We also want to make sure there's no major large fenestrations in the pulmonary valve. We do often see this, but if they're minor, we ignore it. And then once we've decided to proceed, we harvest the proximal part of the pulmonary autograft by making a hole into the RVOT, and then we circumferentially dissect out the pulmonary the pulmonary root. The first septal perforator off the LAD comes in this area. This is the septum down here. So as long as we stay superficial, we really shouldn't have any problem with getting into the septal perforator. You often hear people who are kind of, against the Ross saying, well, there's a high chance of injuring the septal perforator. Well, knock on wood, we haven't done that yet. The LAD lives just over here laterally, so one has to be careful, but the coronaries are obviously avoidable. So in that patient that I referred to earlier, the helicopter pilot with critical AS and normal aortic dimensions, we simply did a Ross, no annular stabilization, no aortic replacement. You can see here's the post bypass TEE. It, essentially looks like a normal aortic valve, and you can see the tricuspid structure and short axis here. And here's the gradient coming out of the OR. Mean gradient was 2.8, peak gradient was 7. And unlike the prosthetic valves, whatever mean gradients we get in the OR, they're often double when we do our post-op day 4 echo, whereas the Ross, they usually remain relatively low. We sort of looked at results already. This is kind of similar, again, looking at more survival data up to 24 years. Ross compares very well to the matched general population. and looking at aortic homograft reintervention. So autograft or homograft reintervention at 10 years, the risk of reoperation on either the aortic or the pulmonary side was freedom from reoperation was 93%, and at 20 years, freedom from reoperation was 70%. So is the Ross the right operation for your patient? Well, we have to balance age, valve lesion, annular diameter, the type of valve disease. There are certain patients who we probably wouldn't offer a Ross to, surgeon comfort and level of experience, lifestyle and expectations. What's favorable anatomy for the Ross? Well, patients with normal EF, pure aortic stenosis, annular dimensions between 18 and 25, which are in the normal range, normal aortic dimensions, tricuspid valve, or a type 1 bicuspid valve, female. This is describing an ideal Ross candidate. If you just give me 1 second here, I just have to check in with the OR. Okay. I'm going to have to get going in a few minutes here. So if one is going to start a Ross practice, one needs to be selective in the beginning, but not too selective. Here's a case that I did, obviously several years into our Ross practice. Patient of Dr. Chisholm's, 50-year-old female lawyer. I don't know why I operate on a lot of lawyers, but I seem to. This patient had an operation at the Hospital for Sick Children in 1981, had an aortic valvuloplasty, but came back with shortness of breath, and the echo showed normal EF, possible bicuspid valve, gradient to 40, mild AR, dilated root, and a dilated LVOT. Here's the three-dimensional CT. Looking at the echo in the CT in short axis, you can see that the aorta is significantly dilated. And looking at it in the coronal planes, there's actually quite a large abnormality of the aortic root. And on CT, the LVOT measured 30, the sinuses of Valsalva measured 57. You can see the calcium in the valve. This valve is obviously not repairable. She meets indication for surgery based on the symptoms, the aortic valve disease, and the aortopathy. So this is what we found at the time of the operation. She had a contained rupture, a chronic contained rupture of the sinuses. This basically a pseudoaneurysm. You can see that it's only the adventitia that held this thing together. And then after inspecting the valve, it was obvious that she had a unicuspid aortic valve. Patients who present in their 20s or 30s with significant valve disease are often labeled as bicuspid. But when we get to the OR, we often find like this, that they're bicuspid. They have a commissure between the non and the left, but they have raphase between the left, right, and right non. So this isn't somebody that I would have considered for a Ross early in my practice. I would have probably done a mechanical Bentall or a tissue Bentall, freestyle Medtronic porcine root for older patients. They do tend to calcify over 10 years, and then the reoperations are somewhat challenging. So these are the various options. And then I say Ross plus adjuncts because of the annular dilatation and the ascending aortic dilatation. So if those who know the Ross literature well, people will say, well, patients with annuli, aortic annuli over 27 millimeters have a higher failure rate. Well, that was true in the literature. However, there are strategies to mitigate that, which may improve the long-term outcome of patients with annular dilatation. So this is the panel on the left. A panel shows kind of a standard Ross where we just replace the root and there's no adjuncts. Panel B shows the Ross procedure, but stabilizing the sinotubular junction if the aorta is over 40 millimeters with a Dacron band so that the sinotubular junction doesn't dilate over time. And then panel C shows both stabilization of the sinotubular junction and, like you saw in the Lansac procedure, which is the modification of the Yakub, which provides annular stabilization externally. One would consider that for patients being considered for Ross that have dilated annuli. So we did a Ross hemiarch, and I provided annular stabilization with a Dacron band. We don't see that here. This is the final result. I'm just getting ready to close. And this is her post bypass echo. She has a little trace of central AI, which is not unusual after the Ross. this doesn't progress, and we don't worry about this. So less favorable anatomy for the Ross would be patients with poor EFs, annuli over 27, but it's not a contraindication because we do provide annular stabilization. Patients with aortopathy, pure AI, again, this would have been considered an older Ross series, a risk factor for late failure, but again, we can mitigate these potential long-term deleterious outcomes by stabilizing the aorta and stabilizing the annulus. None of the top things here listed are contraindications. It really depends on surgeon comfort. Some type of antibody-mediated valvulopathy like lupus or patients with antiphospholipid syndrome. I have done the Ross in these patients. They tend to recur. They tend to redestroy their valves, so we sort of stay away from these patients now. And endocarditis is not a contraindication to the Ross. Even patients with isolated root abscesses that can be patched with pericardium can be offered the Ross, but patients with extensive annular destruction, circumferential root abscesses may not be ideal candidates for the Ross, particularly in surgeons' experiences that are relatively new. I'm going to stop there because unfortunately they're calling me to the operating room. I was just going to show you a case here of a patient who had a Ross 20 years ago by Magdi Yacoub, has come back with an aneurysm, but actually his aortic valve function is still quite good. Let me just show you that. So this patient had a Ross 22 years ago by Magdi Yacoub. You can see there's only mild aortic insufficiency. It's really quite a remarkable result. These are the gradients across the, I guess, the aortic valve are 3 and 6, and across the pulmonary valve, a peak of 12 and a mean gradient of 6 after 22 years. Just goes to show you the durability. This patient's relatively asymptomatic. He has mild, moderate pulmonary insufficiency, and he may require reoperation after 22 years just due to the dilatation of the root. I haven't really decided yet. The risk of dissection in these dilated roots are relatively low, so we may just watch him for a little bit longer. But when he comes to surgery, we may offer him a valve-sparing root replacement on the pulmonary autograft. So let's just go to summary. So aortic regurgitation, we always think a repair-first strategy. And as I said, even though the North American average for valve repair is 13%, that number should be closer to 50 and 60%. For patients who are young and can't have valve repair, we have to consider what the long-term impact of a bioprosthetic or tissue valve is, or mechanical valve, on their long-term survival and quality of life. So we really do, I offer the Ross for most non-elderly patients who are appropriate candidates. Volume matters in aortic root surgery. If you're going to be doing these operations, one needs to be kind of facile with all the various iterations of these operations and be prepared to address annular dilatation and cusp pathology. Otherwise, you'll be limited in the patient group that you can offer repair strategies to. And as anything in life, details matter most. So I'll stop there, and I can take a few questions, and thank you for your attention.
So thank you, Mark. We've been very privileged to have you as a colleague for the last 15 years plus. And Mark is always a surgeon who would come to our echo lab and keep us really honest.
Any questions from the audience, Chi-Ming?
Okay, go ahead. So anyone? Mark has to go.
I can't hear you.
Hi, Dr. Peterson, can you hear me?
Oh yeah, sorry, I had my volume off, so I apologize.
It's Ryan. Thank you so much for those rounds. Honestly, they're really, really informative and very helpful. I'll try to be as quick as possible because I know you have to run.
Sure.
And for patients who we see AVR and they're getting an echo for an AVR,
yeah,
would you suggest that we measure these effective heights and a ZK before their procedures? Would it be helpful for your surgeons?
Yeah. So those measurements are measurements that measure the efficacy and predicted long-term results with valve sparing operations or valve repair operations. They wouldn't be useful for evaluating pre-aortic valve repair or replacement.
Okay, gotcha.
The things that are important to me are, particularly in regurgitant lesions, are EF, because whether it's 52 or 57 matters. particularly if we're doing longitudinal follow-up and they've been at 55 to 60, and now they're 55, and now they're 52, and now they're 50. I have a patient like that who's a general surgeon who I worked with for 6 months as a resident who now needs surgery. And one of the main predictors was increase in the left ventricular end diastolic volume index from 109 to 139, and a drop in EF from sort of normal or hyperdynamic to 50, 52. So those parameters are important.
Got it. Perfect. And for the Ross, is there a threshold when a center becomes low to high volume? Like, have they looked at data on that?
Yeah, that has been looked at. I would say you really, at minimum, well, first of all, you need to have, you can't just start doing the Ross if you're not facile with aortic root procedures. You need to be able to do Bentals in your sleep. You should have facility with valve sparing operations, because don't forget, if the Ross doesn't work, then you got to do a Bental. So you better be comfortable with that. But if you're a high volume aortic surgeon and you're comfortable with root procedures, because the dissection of the root, dissection of the coronaries, many of the elements are very similar to, regardless of whether you're doing valve sparing, Bental, or Ross. If you're a high volume aortic surgeon, I think you can probably get away with doing one a month, but 1 to 2 a month would be kind of minimum volume.
Gotcha. Perfect. Thank you so much again. Honestly, it was very, very informative.
No problem. I probably have
Any
time
other
for
questions?
1 or 2 more questions.
Mark, Bob Howard.
Hey, Bob.
Hi. The great rounds. Thank you. The pulmonary grafts in the Ross procedure. So their natural history, given your data, would appear to be better than if it's in the aortic position. Is that right?
Yeah. So you mean like, does the pulmonary autograft, like the transplanted pulmonary valve, do better than just doing an aortic homograft?
No. I'm worried about the prosthetic graft you're putting in the pulmonary position.
Right. Yeah.
So
I didn't show that data. So you're absolutely right, Bob. One of the Achilles heels of the Ross is pulmonary homograft dysfunction. So just for those who don't know what that is, it's a cadaveric, deceased, cryopreserved, decellularized, basically RVOT pulmonary valve and pulmonary artery conduit, which we sew in to reconstitute the pulmonary side. The incidence of, so there's 2 issues. There's, pulmonary homograft dysfunction as defined by moderate or more stenosis or pulmonary regurgitation. The incidence of pulmonary homograft dysfunction at 10 years is about 30%. But that doesn't mean they're getting reoperations. They're relatively well tolerated if the lesions are moderate. The risk of pulmonary homograft reoperation at 15 years is probably about 10%, 10 to 12, 15%. So there is a number of patients who do require reintervention on the right side. Often that is a transcatheter procedure. But despite that, their survival of patients still matches in most large series that of the age-adjusted population. So obviously, if we could steal the pulmonary valve and didn't have to, and we had a perfect substitute for the pulmonary side, that would be a perfect operation. But that is one of the downsides. But despite that, they still, from a survival point of view, do better than prosthetic valve replacement options.